We are here today to present on the quality improvement processes and outcomes seen from our digitally enabled COVID virtual ward in Gloucestershire. My name is Megan Isaac. I'm the lead programme manager on COVID and respiratory programmes for Gloucestershire, and I'm presenting today with my colleague, Dr. Hein, Roux, who's one of our extremely valuable GP clinical leads.
Thanks, Megan. The overall aim of the COVID virtual ward was to monitor the at-risk patient cohort in their own homes to identify early signs of deterioration with silent hypoxia, so we could escalate their care to hospital whilst also ensuring the remaining patients felt safe during their illness.
The approach to developing a COVID virtual ward was initially undertaken within a testing environment using 3 PDSA cycles, which we commenced using CCG staff and then built upon with well patients in collaboration with a willing primary care network. We worked with an incumbent telehealth provider called Baywater, who provided the test patients with a pulse oximeter and a digital tablet to record their readings throughout the day. We established a multidisciplinary project team who met on a daily basis to assess real-time feedback from the PDSAs and utilised this alongside emerging national guidance to construct a pathway that we could embed locally. Key themes taken from the PDSAs in regards to the clinical pathway and the technological need included the need for a 7-day service, our patient inclusion criteria, the need for engagement and education across the system as we identified the importance of all stakeholders needing to be brought into the vision for the service we were trying to deliver, a two-way communication platform with patients, clear alert parameters that could be tailored for patients with underlying health conditions, options for patients to submit their readings via other means than a smart device, as we were keen not to allow for any digital exclusion, and adaptability in line with the evolving model in response to ongoing assessment and evaluation in real time. Following a phased rollout by PCNs across the county, the team continued to meet regularly to assess the journeys of the patients referred so far. This responsive continual improvement approach allowed us to amend and improve processes as we went along. Examples of such areas are improved referral pathways and additional training for care, nursing and supported living facilities, direct referral pathways from some secondary care specialties, increased comms and engagement with primary care to increase overall referral rates, and adapted onboarding processes.
We adopted 4 main improvement principles. So first, as Megan's already set out, the cornerstone of our successful innovation was the use of model for improvement using rapid PDSA cycles. Second, we used measurement for improvement principles to help us identify and manage our patient safety risks. We had clear outcome, process and balancing measures. Third, we used the Pareto chart principle to understand which patient cohorts were at most risk of deteriorating with silent hypoxia, and thus where we needed to target our efforts to have greatest impact. Finally, using stakeholder analysis, we identified that our 72 GP practitioners were very important to engage with, which resulted in such a high number of patients being referred to the ward. Our key learning has identified 4 overarching themes. So first, we defined our aim as silent hypoxia in at-risk groups, and we worked backwards to achieve this. Second, having a continuous improvement mindset and approach, we were able to rapidly adapt our model as new challenges and gaps came to light. Third, we were very responsive to feedback, which helped us get early sight of potential safety challenges. And finally, we set up a dashboard early on so we could have oversight of the processes, and this allowed everyone to focus their efforts on exceptions and also gave everyone transparency of the whole process as well as all the interdependencies.
Thanks, Hein. So here on this slide, the main graph is showing the number of referrals to the COVID virtual ward between November and April. This metric was our main key success factor, and we've seen over 1,240 patients so far. Alongside overall referrals, we also tracked patient safety scrupulously, which we could gauge based on the proportion of patients entering their readings twice daily as instructed. If they missed a reading, they would alert on the system, which then prompted a call from Baywater to make sure that they were okay. We took many actions to reduce this number of alerts, and we found that reducing the referral to the patient entering their first reading meant that the patient was more likely to stay compliant with the process for the full 2 weeks of monitoring. We also measured the level of referrals to secondary care, which in this instance showed that the more referrals that were made meant that the ward was doing what it was designed to do, identifying those that needed escalation and doing so in times for the patient's lives to be saved. Thank you very much for your time.